So doctor, we have lower motor neuron type, upper motor neuron type, combined type, and the type where both motor sensory is involved, the type where only sensory is involved. That's how the neurological lesions are broadly divided. Let's talk about lower motor neuron lesions. Any problem in the anterior horn cell in the spinal cord or the cranial nerve motor nuclei in the brainstem constitutes a LMN lesion. It can lie in the peripheral nerve or it can be a delivered the nerve root or the anterior horn cell. Upper motor neuron is any cerebral infarction or any corticospinal or a corticobulbar tract is called as upper motor neuron. So what are the features of the LMN kind of a lesion? You know already. It is not spasticity, flaccidity. It is the atrophy of the muscle. Because when the nerve which supplies the muscle is damaged, then ultimately muscle will shrink. Atrophy will be there. Then there can be hypotonia, areflexia, and loss of both the muscle stretch reflexes and also superficial reflexes. Muscle stretch reflexes like ankle and knee jerks become areflexic. If you tap with your knee hammer, there is no contraction in quadriceps or gastrocnemius. There is a loss of superficial reflexes. When you try to strike onto the abdominal surface, there is no contraction of the muscles. Or if you strike on the medial side of the thigh, there is no cremasteric reflex. So superficial reflexes are also gone. Then patient himself will say with a lower motor neuron lesion, see doctor, see my deltoid, it is contracting. See, he will be saying fasciculations. Then if you connect a electromyography and record potentials, electrical potentials in the muscle, you can appreciate fibrillations. They are all the features of the LMN lesions. What conditions can lead to LMN? Poliomyelitis. Classical case of an LMN lesion. Do you find atrophy in a poliomyelitic muscle? There will be areflexia. So why poliomyelitis? Because it goes and affects directly the anterior horn cells. Then there can be few progressive infantile muscular atrophies like Werding-Hoffmann's disease. Then there can be some neurodegenerative disorders like Kujelberg-Wallander's disease, which is also known to typically affect the girdle muscles quite often. Always, what is the rule, doctor? Any myopathy typically involves proximal muscles. Any neuropathies typically involve the distal muscles. There can be weakness of muscle either because of a problem in the muscle or because of a problem in the nerve which is innervating the muscle. But when a muscle weakness is because of a neuropathy, it typically involves distal muscles. Myopathies involve proximal muscles like the girdle muscle. Then what is UMN lesion? Any lesion which is affecting the corticospinal or the corticobulbar fibers becomes UMN. Normally, cerebral cortex, what will it do to the anterior horn cell? It will do what parents will do to the children. Don't do beta, ye mat karo, mai bhi kiya jab mai chota hu. The child will be crying. You did know, you had your chance, let me do, it is my chance. No, my boy, I married a girl whom my father did not accept. Finally, I found it is not really very happy. At least you marry the girl whom I arranged. Then the son will be saying, no, grandpa did like that, he was miserable because it was arranged marriage. And you had a love marriage, it was also miserable. So that is the reason I want to marry the same sex. Try the next generation in a new way. So that way, inhibitions, constant inhibition is what brain will be telling. Don't do that to the anterior horn cell. So if that is interrupted, do everything. Full freedom is for the anterior horn cell and hence hyperreflexia will be there. Now doctor, if there is an upper motor neuron lesion, will it affect the muscles on the same side or on the contralateral side? It depends on, no, not always contralateral. It depends on where is the interruption. So you must know where is the corticospinal tract decussating. It is coming same side, starting from the right motor cortex and reaching up to the lower medulla, no. So any interruption there will ultimately lead to the contralateral side, because at medulla it decussates. But already after decussation, if there is any interruption, then there will be ipsilateral. Agreed? For example, if I have a road accident, if my spinal cord is compressed, right, on my right side, I mean left side for example, then my left lower limb only will show UMN features, because already decussation is over in the spinal cord when the corticospinal tract is descending down. Hence my left lower limb only will get affected if my left spinal cord is affected. So any corticospinal tract interruption above the level of the medulla lead to contralateral UMN, below the level of the medulla will lead to ipsilateral to the side where there is a damage, is what need to be appreciated. So there will be a spastic hemiparesis, hyperreflexia, loss of superficial reflexes like abdominal and cremasteric, there is a loss. Remember, deep tendon reflexes are exaggerated, but superficial reflexes are lost even in UMN. Whereas in LMN, both the deep tendon and also superficial reflexes, both of them are lost. Right? Generally we try to remember opposite. DTR and also superficial reflexes also are exaggerated, we think. If superficial reflexes are exaggerated, you go to any patient suffering from stroke with a UMN lesion, you touch his belly, it should start jumping, no. It should be jerking. In hyperreflexia, no, it doesn't happen. So loss of superficial reflex is common to both the LMN, UMN, but DTR become exaggerated in the case of the UMN, and DTR become areflexic in LMN. Then what kind of spasticity it is called as? It is typically called as clasp knife kind of a spasticity. Whenever you try to stretch a joint, there is a resistance initially and then it fades off. Like the opening of a pocket knife is called clasp knife. Whereas, if there is any interruption in the rubrospinal, vestibulospinal, olivospinal, tectospinal, these extrapyramidal tracts are there, no? Or if the problem is there in the basal ganglia, what do you get? Rigidity, not spasticity. How do you elicit rigidity? If you try to stretch a joint, throughout the motion there is a resistance. Then the lesion is there in the extrapyramidal. Whereas initial resistance, then giving up is clasp knife spasticity, which is feature of pyramidal. Of course, a common question we ask our physiology teacher is, sir, why clasp knife in pyramidal? Why throughout motion there is rigidity in extrapyramidal? Have you got doubt anytime? See, what are the two pyramidal tracts that we have studied? Extrapyramidal. Extrapyramidal, which we have studied in the earlier chapter, were rubrospinal, vestibulospinal. Which is supplying flexors? Rubrospinal. And extensors is? Extensors is vestibulospinal. Right? So that is the reason in an extrapyramidal tract both flexors and extensors are affected. Whereas that is not the case in pyramidal. Pyramidal will go selectively and innervate only one type in upper limb, other type in lower limb. And hence there is a resistance not throughout the motion. Clasp knife only you will have if it is pyramidal. Okay, doc? So once more we will discuss this in decerebrate decorticate rigidity. What is the type of muscles does this basically innervate? Then clonus. Once more is an important sign of that increased tone in the muscles. Tone is different from power. Don't confuse. If you make lie down. I'll ask you to raise your hand. You are able to raise. Then I will apply resistance and ask you to raise the hand. What I am testing in all these maneuvers? Power. Whereas I am trying to stretch your joint. What I am trying to test? Tone. Tone is controlled by cerebellum. Right? So, cerebellar lesions typically lead to hypotonia. Tone is also controlled by corticospinal, and hence any loss of corticospinal inhibition will make hypertonia. And one of the features of the hypertonia manifestations is spasticity and clonus. So you take the ankle and then try to make it flex, and that typically will lead to rhythmic contractions, which is called clonus, which is a manifestation of excessive tone, is what you need to remember. Then comes the Babinski. There is no Babinski negative. Still we use the word Babinski positive. Right? So there is nothing like hate marriage. Still we use the word love marriage. Any marriage is meant to have love. So Babinski also suffers a similar problem of terminology. There is no Babinski negative. So okay, what is Babinski? Typically, it is a plantar flexor response. Foot is there, no? Look at the big toe. It will typically move up, and the plantar reflex, which will be going into dorsiflexion, which makes the Babinski sign to be present, which is typically seen in the case of whenever you strike onto the lateral surface of the skin on the sole, then there is a fanning of the toes along with the extensor response, dorsiflexion of the big toe, which makes it Babinski positive. Then we have that's all the story of lateral corticospinal is over. Remaining tracts are very easy. They're lesions. The ventral corticospinal tract lesion, it leads to a contralateral motor deficit, and now comes a very important few examples of where you find this kind of corticospinal tract involvement. There's an entity called hereditary spastic paraplegia. Hereditary spastic paraplegia. Spastic itself means corticospinal is involved. So there is a bilateral degeneration of the pyramidal tract in these people who have hereditary spastic paraplegia, and that lead to development of the spastic weakness of the legs with the difficulty in walking. That's the whole problem in them. Then now let us talk about the sensory pathway lesions. Now, dorsal columns can get demyelinated if you have vitamin B12 deficiency or whatever the reason. Then we get what are called dorsal column syndromes. Dorsal columns include fasciculus gracilis and cuneatus. Subacute combined degeneration of spinal cord which occur with the vitamin B12 deficiency can involve the dorsal columns. Then similarly, in neurosyphilis, tabes dorsalis is an important entity where selectively dorsal columns get affected. Then non-syphilitic sensory neuropathies will be there. Even in them also, the dorsal column is typically involved. Now, if the dorsal column is involved, what will happen? Tactile discrimination ipsilaterally will be lost. Position and vibration ipsilaterally is lost. Then if I put a coin in your hand, you can't feel it. Which type of coin? Closing your eyes, and hence you get asterognosis. Then whenever we walk, cerebellum will be told information coming through the eyes and from the touch. So if the dorsal columns are affected, the touch information won't come to cerebellum, and hence we go into ataxia. Until our eyes are open, we don't go into ataxia. You ask the person to close the eyes, then he depends on a touch to maintain balance. If the dorsal columns are affected, the touch is not going to cerebellum, and hence he goes into ataxia. And what is that called as? Wash basin phenomena. Typically, patient will be talking very nicely. He is a top politician. Next, is he going to become CM or PM? He will be talking, and he is going to the wash basin, and he splatters the water onto the face and collapses, because he had a problem of sensory ataxia, classically. Then, monosynaptic stretch reflexes have an afferent and efferent. Afferent information can get affected. So that is the reason there can be eriflexia or hyporeflexia, which can also be the feature of a dorsal column lesion. Then, dorsal column also brings information about the stretch of our viscera. So that is the reason there can be urinary incontinence, constipation, impotence. Anything can be the problem if the dorsal column is affected. Then Romberg sign will be typically positive. That is, you ask a person to walk in a tandem line, then with the eyes open he is able to manage, because the visual information cerebellum is maintaining. Ask him to close and walk, then he will be swaying. Is typical of Romberg sign positivity on closing the eyes in case of the dorsal column lesions. Now, how about the spinothalamic tract? Contralateral loss of pain and temperature will be there. But one important thing that you need to remember is if my T1 is affected, T1 level may, if I have an interruption of my spinal cord, if you are touching, where is my pain sensation gone, pain and temperature gone, it will be one segment below that of the area where there is a lesion. So it will be typically one segment below the level of the lesion in case of the loss of the pain in case of spinothalamic tract. Now, the next important tract is the ventral spinothalamic tract. So in the ventral spinothalamic tract, there is also loss of light, crude, the crude touch sensation, right? So this will be 3 to 4 segments below the level of the lesion. It all depends upon how is the decussation happening. Then you have after the ventral spinothalamic, you have the dorsal spinocerebellar tract. So if there is a dorsal spinocerebellar tract lesion, there will be cerebellum is with maintaining balance. So it is an uncrossed or a crossed tract. Uncrossed tract. So there is a reason there is an ipsilateral leg ataxia. Only leg ataxia. Then you are having similarly after the dorsal spinocerebellar, you are having ventral spinocerebellar tract. But this is a crossed one. Hence there is a contralateral leg ataxia. Then that's all the story of the various tracts. Will they be contralateral, ipsilateral? Same segment, one segment, 3 segments down. There's a whole challenge of remembering in these various lesions. Finally comes peripheral nervous system and the lesions of it. They can be motors, sensory or combined, and it can affect the spinal root, dorsal root ganglia or the peripheral nerves itself. So can you give me a few examples of where peripheral nerves got affected, doctor? Herpes zoster. Typically it involves territory of only one dermatome. Herpes zoster is very common between T5 to T10, and it leads to irritation of the dorsal root ganglion, which is the place where your first order neuron of the most of the ascending tracts are all located. So that is a herpes zoster story. Then what is Guillain-Barré? It is also called post-infectious polyneuritis, where after an infection, the same microbe which caused infection, antibodies against it are also acting against the myelin on the motor nerves. and there is a selective demyelination of the motor nerves, and that is the reason there is a lower motor neuron type of symptoms due to the demyelination of the motor neurons, and hence there is a weakness, flaccidity and a reflexia because of that. And what kind of paralysis it will be? Unlike the poliomyelitis, which will go and selectively affect the anterhorn cell only on one side, where the poliomyelitis weakness is asymmetric weakness. Did you see both limbs polio? It may happen, but rare. But both sides flaccid, symmetrical paralysis is due to the demyelination of the motor neurons on both the sides in case of Guillain-Barré. Whereas asymmetric flaccid paralysis is a feature of poliomyelitis. Then what kind of weakness it will be? Typically it will be ascending weakness, which will be typically involving the trunk and upper extremities. It will be going up. And facial nerve also can get affected. And if you take the CSF, you find albuminocytologic dissociation. There is elevation of albumin, but not a concomitant elevation of the cells. Unlike in bacterial meningitis, what will happen? In CSF, in bacterial meningitis, both the albumin and also cells, both of them are elevated. It's not like that in Guillain-Barré. Then are there any conditions where you can get in the same patient both the upper motor and also lower motor neuron features in the same patient? Yes, sir. It can happen in a condition like amyotrophic lateral sclerosis. Right? Amyotrophic lateral sclerosis. What is the other name given for it? Lou Gehrig's disease or the motor neuron disease. Both LMN and also UMN get affected. Why UMN get affected? Basically in this there is a sclerosis of the corticospinal tract. Hence UMN. And anterhorn cells get degenerated. Hence LMN. So both the kind of features you will find in the case of the amyotrophic lateral sclerosis. Sometimes in amyotrophic lateral sclerosis, motor neuron disease, only pure LMN component can be there. If pure LMN component is there, then what do you call it as? Progressive muscular atrophy and progressive bulbar palsy. But if it is a UMN component predominant, then you call pseudobulbar palsy or primary lateral sclerosis. But UMN LMN combination also can occur. When the combination occurs, what is it basically called as? It is then called as amyotrophic lateral sclerosis. Generally upper limbs will show LMN features, lower limbs will show UMN features in the case of the motor neuron disease. Now doctor, let us talk about a condition like hemisection of the cord and a complete transection of the cord. What will happen? And then we call it a day, that we are done with the spinal cord, its ascending, descending tracts, their second order neurons, blah blah blah, and if God permits we remember in exam, good. If we don't also, no problem, we have studied and forgotten, we will have satisfaction. Brown-Séquard. What will happen in this? Half the spinal cord is cut. Some problems will be ipsilateral, some will be contralateral. Dorsal column in the spinal cord level may, how it is, already it became intelligent and already decussated, or still it is innocent. It is still like a first year MBBS student. Dorsal column in a spinal cord level may. So ipsilateral loss of tactile discrimination, perception, position, vibration, everything is gone. So same side of the lesion you will have loss of dorsal column and corticospinal tract. We said no, above medulla corticospinal is interrupted, contralateral weakness. Spinal cord level may it got interrupted, then ipsilateral features is what we typically come across. Then contralateral side, what do you get in Brown-Séquard hemisection? Pain and temperature, which are coming from the contralateral lateral spinothalamic tract. Then ventral spinothalamic tract, which is also decussating, is interrupted in hemisection, which is a crossed one, and hence contralateral loss of the crude touch will be typically found, and it will be 3 to 4 segments below. Then dorsal spinocerebellar tract on the same side, which is not decussating, is interrupted, and hence there will be ipsilateral leg dystaxia in case of the hemisection. Generally hemisection and Brown-Séquard syndrome means we only remember ipsilateral dorsal, ipsilateral pyramidal, contralateral, spinothalamic, ho gaya, pain and temperature. But if the examiner likes to ask which side will be the leg dystaxia, first of all we don't know why leg should have dystaxia if the hemisection is there. It can be there because of the spinocerebellar tract involvement, and that will be ipsilateral leg dystaxia because dorsal spinocerebellar is undecussated tract in the spinal cord, whereas there will be contralateral loss of crude touch because of ventral spinothalamic tract lesion. These two additional points in Brown-Séquard hemisection of the spinal cord you should not basically forget of it. Then suppose that hemisection has occurred rostral to the T2 somewhere in the cervical area, what will happen? Then the seriospinal center of budge in T1 get affected, and that typically lead to development of sympathetic nerve paralysis. Horner syndrome can occur, right? Then pyramidal tract transection will be ipsilateral when there is a hemisection because already decussated and came and it is trying to go down same side. So ipsilateral spastic paresis will be there, ipsilateral Babinski will be there, ipsilateral whatever it is there. Then ventral corticospinal, first of all, is it decussating, undecussating? What will it do? So that if you know, you will answer. Ventral corticospinal tract typically will lead to a small amount of contralateral muscle weakness below the lesion. Not really that important. So that's all the story, doctor. Now, complete transection of spinal cord, very common situation in the case of the road traffic accidents. What will you get? C1 to C3, if there is a complete transection, we go and join Lord Parameshwar. It's called as exitus letalis shivalis. So go to the Lord Shiva and die. C1 to C3 people are not compatible to exist, right? C4 to C5, both upper limb, lower limb fibers are passing through it, hence quadriplegia will be there. Any complete transection below the level of the T1 only will affect lower limbs, not upper limbs, because upper limbs already have entered above T1. So paraplegia will be there. Then always when there is a complete transection, at the level of the transection, what will be features? It will be a element type because Anderson cells are affected. Below the level, the descending pyramidal tract is interrupted, no? Hence below the level, UMN features. Full freedom, hyperreflexia, everything, joints will be dancing. At the level of the lesion, the joint become areflexic. LMN features, right? So that's what need to be remembered. Then there can be complete anesthesia below the lesion. Urinary fecal incontinence will be there, right? Because the urinary and defecation are regulated by the upper centers. There is also local regulation that will be still retained. So automatically the bladder stretches and empties, that is local reflex. That won't be affected. But from the upper part, the control is descending down, no, that get interrupted. So that lead to development of urinary and fecal incontinence, but reflex emptying still will be there. Since sympathetic system may get interrupted in upper lesions, that can lead to anhidrosis, just like in Horner. Then there can be paralysis of breathing, especially whenever there is any transection above C5, because phrenic nucleus is found between C3 to C5 is what need to be remembered. So that's all the story, doctor. 8 o'clock means we should not study beyond it. So there are few more things we'll finish tomorrow and we will continue with brainstem. Don't leave it in the home, bring it to the classroom. So once you understood brainstem, cranial nerves already more or less we finished except last 2-3 cranial nerves in the previous class. Then some small things about embryology of neuroanatomy, 2-3 things we cover. Positively by Friday, we should say we are done with neuroanatomy. Then another 1 week we will take for gross anatomy at max. So that's the whole idea. So thanks for your patient listening, doctor.